We're here at the CROI in 2016 here in Boston, Massachusetts. I think it's a sunny day out there today. And we're here to talk about aging and HIV. We're here with distinguished people from the world of aging in HIV. We're here with Alan Landay from Rush University Chicago, with Peter Hunt from UCSF, and with Seema Desai, also from Rush University Chicago. And we appreciate you taking the time. I know you already have some other commitments, so we're going to make this quick, but also informative. So hopefully we'll move through the things that you want to talk about quickly. Shall we start out on the end with Alan? Anything you want to bring to the program today?
Well, I think you know, there have been some advances in the last couple of months in terms of when to start therapy, and the START trial that was presented at the Vancouver AIDS meeting has taught us a lot about starting when we first find a person who's HIV infected, and I think that's going to have a lot of implications in the aging field in terms of looking at the comorbidities as we start earlier before there's an immune decline, and also before the viral loads are established a larger reservoir. And so I think we'll hopefully be able to see more outcomes now that we're changing the paradigm, which is really on a global basis from the WHO guidelines for starting, as well as all the other national guidelines. So I think we're going to see some impacts in the fields of HIV and aging in the next couple of years because of this.
Okay. And Peter, what are you bringing to this meeting?
Yeah, I would follow up on what Alan said, and there have been a few presentations at this meeting, and then we'll also have already been a few other presentations related to what morbidities seem to get better with earlier treatment. And one of the surprises has been is that not all morbidities appear to benefit from immediate treatment versus a delayed treatment by about a year or so. And that could be because the morbidities are already established, and the extra year doesn't make a difference, or that certain morbidities might not have yet established themselves. So some diseases, like there's debate as to whether there's neurocognitive dysfunction or early dementia in the very, very early stages of infection, or whether you need progressive untreated HIV disease before that starts. And so I think a lot of it suggest how important it is to really follow through with the WHO guidelines and start treatment early to maybe prevent the establishment of some of these diseases.
So when the physician recommends, suggests that a person go on treatment, and they should probably recommend right away, and the patient recoils and says, they think that's the time when they're really sick. So there's a psychological barrier. How do you feel that should interplay? I mean, I know there's could be physicians watching that think about, how do I address that? How do I challenge the patient to, this is really important. It shows that you should be on treatment immediately, and how that may benefit them.
Yeah, I mean, well, I think really talk about every patient. I'm also a clinician, and so I've had many of these conversations with patients, and what I can say is every patient is different in terms of how they approach the issue. And I've had some people who I've tried very hard to convince for years to go on treatment, and it's trying to understand what the barriers are for them, what they're worried about, and really trying to address those issues up front. And then just share with them, have an honest conversation about what the data shows and what the evidence is, and how dramatic the differences are in people who start early versus delay, and thinking about the future. Everyone wants to have a healthy life, maintain function, and be healthy as they age, and while a lot of the things that we're talking about preventing, may not be evident tomorrow or the next year, 10, 20 years down the road, it may make a big difference in terms of the morbidities that people have and how functional they are. And so we want to help preserve long-term function for our patients.
And we also talked earlier before the program here about the elite controllers. Even there, it seems to be an interest because there's this underlying inflammation that goes on that can be deleterious over time.
Yeah, I think there's more and more discussion about the elite controllers who control virus replication in the absence of therapy. Many of them, while they're able to do that, they still have abnormal levels of inflammation, and it's possible that could contribute to an increased risk of several diseases like cardiovascular disease and otherwise. While we don't have definitive clinical data because there's such a small part of the population, there's certainly that theoretical risk. But that said, there are probably some HIV controllers who have very low levels of inflammation and are able to control the virus, and it's those individuals who probably have can teach us the most about how to effectively lead to durable asymptomatic remission for HIV.
Or cure or something like
Yeah.
that. Yeah. Well, Seema, what do you have to say today?
So I think this CROI is very special in a way that there have been some papers that allude to advances made in immunology per se. This year there are presentations that are related to chronic HIV and how the different trials, and in respect to aging, I think there was a session on neurocognition, and it was called The Beautiful Mind. It was presented yesterday. It was an excellent session, and they have come up with some excellent biomarkers, which was some of the advances that were much required. Neurofilament light protein was one of the biomarkers that was associated with neurological outcomes in that study. Said that the rest or many of the papers presented are on barriers to cure. I think, as you alluded, inflammation is really a very important aspect that needs to be taken care of, and to make a perfect case for for cure, you certainly want to make sure that your immune system is functional, and many of the presentations were about augmenting CD8 responses that keep the virus under control. And that said, I think strategies that target the immune system as well as viruses would be required to prevent comorbidities and de-accelerate aging. I think so.
I mean, as far as a cure at some point.
Yes, for cure at some point.
I haven't seen much on immunology. I think that's, like you're saying, maybe that's just the next piece of it that needs to be discovered.
Because last year I think many papers were on innate immunity pertaining to monocytes and inflammation. This year,
immunity.
yes,
Yeah.
and this year there are many papers on adaptive immune responses, and I think it's very critical at this time when we are moving towards functional cure that we look at adjuvant therapies to fix the immune system, at the same time take have strategies to control viral replication and reverse latency.
Mm-hmm. Go ahead.
I think one of the things that I heard from the first plenary from Dr. Aaron this year was that, again, our therapies are so much better. We have so many new options, one pill once a day. And I think with the newer, as he pointed out, the integrase inhibitors, and they're pointing the way, I think, also to the idea that they may have an effect on inflammation. And many people have asked me when I say that, well, is there a mechanism? Is it really the antiviral effect, or are there other mechanisms that perhaps integrases do better on the inflammatory responses? But that said, as we move into the aging HIV population over 50, and I think Peter could comment as well from the clinical perspective, is how to manage their patients, because there are issues of polypharmacy in our patients, and their AIDS meds in the past have been an issue of taking 20, 30, 40 pills a day, and now as they're getting older, they're going to be dealing with their diabetes, their heart disease, all their other comorbid conditions that they may have from just the natural aging perspective. And I think that becomes an issue that you're going to be looking at. Some of the lifestyle issues, the AIDS issues of treatment are hopefully going to be less complex, maybe a little easier. And we're looking at even newer drugs that are going to be long-term effects or even implantables down the line. But I think that's going to perhaps change the paradigm of how the aging or over 50 HIV population. I hesitate to say over 50 as the aging population, but I think from many of our definitions, that's what we're looking at.
Well, we also looked at over the time, whether you called it aging, which means not aged, but people who were aging faster at any age. And I think it is more profound, I guess, in the older you get. But it seems as though that we figured all, I mean, that was the first thing we said when people, the early days of AIDS, said it looks like it's an aging disease because everyone gets old and frail and dies. So, but this is a little different perspective. It's even on treatment, you still have that aging, accelerated aging, and then accentuated aging, someone else called it. I don't know which you would prefer to use.
Yeah, I think accentuated aging may be more accurate because it's not it's not that the aging process is sped up, but at any given age, people living with HIV in the modern treatment era have a higher risk of many of the diseases that we normally associate with the aging process: heart disease, cancer, osteoporosis, and so. So it's the accumulation of many of those diseases that, as Alan says, is more and more of a challenge for the HIV doctor now because you're managing multiple different morbidities besides the HIV, and the HIV in many cases now is the easiest one of them to treat. We now have many single pill once a day regimens with minimal drug interactions, minimal side effects. And it's really balancing, and that's a godsend for managing these other morbidities, to minimize polypharmacy, minimize those drug interactions for things that you need to treat, like the high blood pressure, the high cholesterol, or treating low bone density, for example. So I think we've come such a long way, I think, with treatment, but now we, as HIV doctors, are really taking we've always had a holistic approach to treating HIV, but now it's probably even more so as we're managing all the other morbidities.
How important do you all feel it's to maintain a relationship with one physician, such as, like you said, an HIV doc who covers it all, and how much of it do you actually cover? Do you refer the bone disease, or do you refer the cardiovascular? And another thing I wanted to talk about later maybe is mental health, which was almost not covered here at this conference.
Mm-hmm. Yeah, that's. I'm glad you asked about that. I mean, I think the depending on the comfort level of the HIV infected HIV clinician, he or she may have really strong general medicine skills, be able to manage a wide array of different problems. They may be more targeted in their comfort level, and they may be referring more. But in either case, there is going to be much more multidisciplinary care. Physicians and clinicians working in teams to manage patients, and their communication between providers is so important to make sure people don't add on a new medicine that may interact with something that they're getting for the HIV. And just to coordinate the care in general, that becomes more of an issue. But you also asked about other issues like mental health. And it's very depression, for example, is very common in HIV, and represents a major barrier to managing the HIV itself, as well as many of the other morbidities. And so I think oftentimes in the multidisciplinary care model, there's ideally you should have integration with psychiatrists, psychologists, substance abuse specialists when that's an issue, with the HIV care programs. We heard a really wonderful presentation from Jerry Friedland to start the conference about how important it is to really integrate all those things together in the care, and how powerful that can be. I think that's very true.
Yeah, that may have been the reason they put him there, because it seems though I searched the keywords, and I came up with one presentation on mental health. Now I'm sure there's others that had touched on it or were designed in maybe different keyword, but it's a little bit scary because a lot of doctors are really concerned about that with their patients, because and so we can't just say, oh, don't be depressed. Well, it's easier said than done, and a lot of folks need that, to be exercising and to be eating the right foods and to be full of enthusiasm for their lives and living. And we just had the program on Prep for Love, getting people to be normalizing their life with sexual activity, which is another thing that a lot of the people living with AIDS fear or feel incomplete about.
I'd also like to add, maybe, and Seema could comment, is looking at some of the lifestyle issues in terms of smoking and drinking, and I know those are also going to be things that dealing with that are going to contribute to the ongoing inflammation. I know that's something that Seema is actually presenting on this afternoon, and can talk more about from the perspective of how these lifestyle factors affect inflammation and comorbidities.
So I do think what you said, exercise and better living, because substance abuse or alcohol do contribute to inflammation, additive to what HIV already does, despite art. So I certainly feel that these issues have to be taken care of, and you want to have, in your model, you do want to have these modifiable factors accounted for, and as Peter said, it's no longer a single disciplinary setting that would work. You do need different expertises as of what the epidemic is now. It's aging, and age-related conditions do need to be treated as they are in any aging setting, not per se as in an HIV treatment program.
And to follow up on that, I think there are lots of interconnections between these lifestyle changes and the lifestyle factors and the immunologic factors that we think drive disease, the inflammatory state. Exercise may reduce inflammation and improve depression. Smoking may increase inflammation as well. And so these major lifestyle changes that are within our patients' power now. Something they can take control of without taking a new medicine, without waiting for new research. Working on quitting smoking, working on trying to exercise more can be very powerful in reducing risk for all sorts of different diseases.
When that improved or increased metabolism, isn't that what it is that's actually changing everything? It's that movement, and because they say you have to walk a little bit each day or something, but you can do more than that. Maybe you can slowly, eventually, especially for older people, no quick becoming an athlete overnight, but slowly improving the amount of distance you go or the amount of rigor you put forward, but doing it all the time and increasing it slowly, and maybe even almost every day, a little bit every day would be helpful.
No, I would agree. I think we're starting to include in a lot of our evaluations, the sort of current use of Fitbits that people wear, and just as a way of sort of motivating people. And I don't know if Peter actually gives those or even says to his patients they should wear those as a way of motivating. I don't have mine on today, but I used it when my wife bought it for me a year ago as a way of sort of motivating me to climb the stairs every day when I go to work. And so I think at any age it's a great motivation to help do a little bit more and try to evaluate that. And I think certainly, as was pointed out, the impacts of mental health, all of those aspects are going to affect the immune system. So I think we're always going to come back to this sort of unifying theme of how the immune system and inflammation might play a role in these outcomes, and that things that we can do to intervene are going to be very valuable for doing that, and even simple things. And one other thing that may be worth discussing, because we're now looking at an era where we're actually treating HCV and coming to sustained virologic cures and remissions, and I think that also is changing the paradigm perhaps of how HCV has affected our look at HIV as well. Maybe Peter or Seema would comment on that.
So even for co-infections, I think I would agree that if you decrease the inflammation burden, which comes from better lifestyle, certainly the success or effectiveness of either HCV eradication or HIV treatment would be better. So I do think that aging, as we think, or age-related comorbidities are associated with the same inflammatory mediators that are seen in aging disorders. So having said that, we do want to make sure that we take care of immune pathogenesis at the same time or as we do for our strategies towards viral control.
Great. Before we conclude, I want to make sure I didn't miss any something you brought to the table this year. Is there anything else that you want to bring forward?
Well, I think I think we're going to learn this afternoon. There's a symposium looking at all the different organ systems in terms of the bone, the metabolic. I've been particularly interested in, and I think maybe Peter and Seema as well, in the liver. And there's going to be some discussions about liver disease in the context of HIV. I think Hep C has really pushed us in the direction, certainly, of the liver, but I think there's also a lot of underlying effects of HIV we haven't yet explored. And as people are getting older and what effects that has on liver physiology. I mean, the liver has a huge physiologic reserve, but does that change over time in aging? And I think there's just so many things that we can think about understanding more about normal physiology. And I think that's one of the things that HIV as a field has taught me, is that we can learn a lot from other fields as well. And I think it's especially true with some of the newer drugs, the checkpoint inhibitors in cancer. That's changed the whole face of cancer therapy, and now is really beginning to move more into the HIV field as well.
Yes, I think that's something that we didn't, this year I think there were presentations on PD-1 blockers this morning as well, and checkpoint inhibitors are currently the ways to move the paradigm forward, but I guess the resolve is not going to be in one particular strategies. It will have to be multiple ways of targeting, as I said, inflammation as well as comorbid conditions, better treatment, better care, mental health, and various other issues. So I'm sure this CROI will have a lot of presentations today and tomorrow that are related to aging as well.
We do this before the CROI is over, but
yes,
you
this
see
year
the
is
abstracts. But you see the abstracts,
yes,
and you know what's coming. Yeah, pretty much familiar with it. Yeah, and we've ended up with so many different aspects that are not covered. Like I said, mental health, but there is so much going on at this CROI, and it's incremental. It's not a magic bullet. It's silver BBs everywhere. There's just a lot of little pieces that collectively, which is the reason you're here, you learn the pieces that might help you in your practice and your research. We appreciate you all participating. Thank you very much.
Thank you.
Well, thank you so much for
Thank you,
inviting
Fred.
us again.
Very good.
Thank you. Bye-bye.